We're going to get him up here. We're going to go through our active passive resisted tests. Dorsiflexion is going to look limited. We're going to get him into this position. We're going to do our Taylor swing test, and it's going to look limited with that pathomechanical infill right there. You can feel it very well in anterior glide. External rotation is not as bad, so this is just an anterior subluxation. Okay, swing your leg around here, scooch back for me. There we are. Now, here's a few things that we have to take into consideration. So, if we've done our ligament stress testing, which we did, stable there, and we've looked at plantar flexion, and plantar flexion is full. I'm not terribly concerned about anything in this ankle and just doing a straight distraction technique, right? Joint capsule looks pretty good, right? Because there's no capsular pattern. There's no ligamentous instability here in the anterior components. So there's nothing really here limiting me from doing a straight distraction technique. Okay, to do that, a few things that we have to take into consideration. The force that we use to put through this joint will transmit up the leg and potentially into the lumbar spine. So we want to try and put as little stress on the lumbar spine as we can. We're going to have him lay all the way back. Right? That's going to put less tension on the dural system, right? Less stress on any of the hip structures or any of the sacroiliac structures, etc. We also don't want him sliding down the bed, so we're going to bend this knee up and put it here so that the foot will help stick him to the bed. Okay? To perform the technique, we need to be on the neck of the talus. That's my ring fingers, right? So I'm going to interlace my hands here with my ring fingers exposed. You guys all see that? I'm going to slide down the front of the tibia until I get to the neck of the talus, like so. There's my grip. My thumbs are going to be just over the middle 3 metatarsal heads, just like this. Okay? Squeeze my hands together. Elbows come together like so. There's my barrier. You can probably see here, if I push down into the table just slightly, now I get less movement out of his trunk, right? If I have him up like this, you can see where his leg starts to move. A little pressure down here, now I get less movement out of the leg, right? Minimize the stress up the chain as best we can. So there's our grip. I'm going to lean back, or in this case, I'm going to push back with my foot to engage the barrier, right? I'm trying not to use the body region to produce my barrier, to engage the barrier as I am to produce my thrust. My thrust is going to be here, right? Pull my elbows towards my side in an adduction motion, like that, right? That's fast. Doing this, that's not fast, right? Elbow flexion, that's not going to be any good.
How much plantar flexion do?
About 5 degrees. I'll tend to, so here, about 5 degrees of plantar flexion, a little bit of internal rotation. Okay, now if I'm having to do an external rotation technique, I may take them out of that internal rotation and put them more here. Bias up toward an external rotated position. So, you okay if we go ahead and manipulate?
Yeah.
Okay. So here, I'm going to press back with my foot. There's my barrier. And that. Nice loud pop. So here's a question. Right, this is a unique thing. When we get that sort of loud cavitation of a joint during distraction, what does that suggest to you? The way I think about it is, yesterday when we were talking about the potential causes for subluxation, right? The common theory I think that most people get in their heads is that we have a joint that's just slid off the rails, right? It's gone to an extreme of motion, it's gotten stuck there. I think looking at every subluxation that way is a bit short-sighted, right? Because if that's the case, when I pull here, I wouldn't get any noise, right? It would give me this and clunk, right? But in his situation, when I pulled, it snapped on the pull. So this is why I tend to believe that there is such a thing as a synovial tag, where the joint surfaces has contacted and they've stuck together, right? And then that way when I pull to create that distraction, that's what gives us that loud cracking cavitation sound. Does that change anything for us, particularly with the technique, with their rehab? It might. If you think about the idea that that probably affects joint volume, the fact that those two surfaces have come into contact. So we need consistent range of motion here, good habitual close packing of this joint, which would essentially be dorsiflexion with external rotation, right? So we'd probably give him something to take home that facilitates that. I'll show you what that sort of stuff looks like in a little bit, but you got to kind of at least consider that as something when it comes into how are we gonna work on this sort of thing. Somebody that just has this kind of pull, soft pull with the clunk coming back, there's likely some micro instability with that, right? So now we're looking at having to do some single leg stance training with this patient, maybe some proprioceptive training, maybe some sensory training on the bottom of the foot, looking at plantar pressures as opposed to the joint moving, right? Proprioception means that the joint's already moved. A lot of times it's too late by then, right? Joint's already over here, you've already fallen over your ankle, right? But sensing where the plantar pressures go on the bottom of the foot before the ankle is actually moved is actually a much faster sensory feedback mechanism. So consider that as you will. I use a, I didn't bring it with me, I should have brought it with me. I use a massage ball. Okay, it's got these little divots and grooves and protrusions on it, and it's very good for actual sensory feedback on the foot. So we'll lay that down after we do the manipulation, lay that down, and we'll have them roll that over the plantar surface of their foot, right? Pressure, reception on the bottom of the foot. Try and stimulate that now that we've corrected whatever these biomechanical faults are. Probably not as big a deal with the ankle, but if you think about somebody that has a sublux cuboid, right, medially rotated cuboid that's pressing into the plantar structures of the foot, that's going to jumble up that plantar sensation perception pretty quickly, right? And we'll probably see that. We can look at that if we find somebody that has a tarsal subluxation of some kind or first metatarsal subluxation of some kind. We can watch them in single leg stance. We'll try them in a couple of different positions here with eyes open, eyes closed, and spinning the head so that we're stirring up the vestibular mechanism. See how their balance looks there. We'll manipulate it and then we'll reassess. Right? Actually, we could do something on the bottom of their foot there as well to help with improving that sensory feedback, but that's something we have to consider, right? Anyway, I just wanted to mention that based on the sound that we got with this, right? Let's, let me show you the other manipulation before we go back and retest anything. The other manipulation for the talocrural joint is the J-stroke. Okay, the J-stroke, the difference here is going to be the thrust is in a J shape, right? So there's still distraction, but we're going to scoop down into posterior glide and then produce the distraction. So it's this sort of motion. Okay, this is a much, much better technique if we have somebody that comes in with anterior ligamentous laxity. Okay, because as I produce that downward motion, I'm going to slacken off the anterior structures. before producing my traction. Does that make sense? Outside of that, there's not a whole lot of reasons that I'd use this over a pure distraction technique. If I had a patient that just had a really stubborn anterior subluxation and I just wasn't getting it, I might try the different technique just to see if I got a better result. But for the most part, I'm going to use the straight distraction technique. There's just less confusion from a body movement perspective for us as the therapist. So with this, we need something to prop up his foot. So what we're going to do is we're going to roll up as tight as we can get a towel roll. We're going to put that under the back of the mortise, right, so that the calcaneus and talus are still free to move. Handhold is the same. We're going to take him up into dorsiflexion now, and if I need to, I can go into a little external rotation. Bring him back. Again, I'm pushing back with my right foot. Engage my barrier. I'm losing my fixation here because of the towel. Right there. And then my thrust is here, down to the floor. Squeeze the arms together. That. Right, so this sort of motion. So there is a ulnar deviation along with the squeeze of the arms. Right? Like that. Okay. Any questions?